I'm also excited about the fact that as we have entered into an agreement with UNCG for our partnership school that'll open up in the fall, that part of that initiative we're looking at going in with Cone Health and setting up a student health center at Mall Street School. So I'm really excited about that partnership school because none of us could do it alone, but together we can do a lot. And so that's what we're really excited about. It's my pleasure to be able to introduce Cathy De Mason. She is the director of the Student Health Centers. She has been there since day one. She started out as a nurse at the Reedsville High School Center in 1994, and then the next year she was thrusted into the role of leading this project. And I can honestly tell you, she works tirelessly to make sure that we're able to do this. Somebody asked me one time about 8 years ago when they were asking about the funding should continue for the Student Health Center. And this person said, well, there's only 10% of the high schools with Student Health Center. So why should I fund yours? I said, because the other 90% are wrong.
That's right.
Here's Cathy De Mason.
Thank you. And let me just say, we don't have the PowerPoint right now, but we're hoping to get that loaded onto your e-board at some point, so you'll have this information. Thank you, Cathy.
Members of the board, advisors, and all the staff from DPI, thank you so much for this opportunity to be here today to tell you a little bit about the student health centers in Rockingham County. Our mission is to improve the health and school performance of Rockingham County high school students by providing comprehensive health care through education, prevention, treatment, and referral. And I hope you can all hear me today. My allergies, I apologize, are terrible, but tell me if I need to speak up. We're a community partnership. This is an expensive program and nothing one person or one group can do alone. As Dr. Shotwell mentioned, of course, our biggest partner is Rockingham County Schools. And then in addition, we have Annie Penn Hospital, which is a small hospital in our county that is part of Cone Health. We also have UNC Rockingham Healthcare, which prior to January 1st of this year was known as Moorhead Memorial Hospital, another small hospital in our county, and then the Rockingham County Department of Health and Human Services, and we are a United Way of Rockingham County agency. We have a community advisory board, and it's made up of parents and students. We have members of the clergy, principals, school board member, teachers, and other school personnel. We have community and business representatives, physicians, representatives from Department of Health and Human Services, both from social services and public health, and then representatives from each of our 2 hospitals. The services we provide are given by a multidisciplinary team. We really believe in the whole school, whole community, whole child model, and in order to do that, we're not just providing health care, we're doing a lot around mental health and nutrition too. Our multidisciplinary team includes nurse practitioners, physician's assistants, registered nurses, licensed mental health professionals, registered dietitians, health educators, and then we have a position we call a medical clerk who is a receptionist and does everything and kind of runs each individual center. We are embedded into the school system. We work really closely with the school nurses, the school psychs, and other school staff and our SHAC team. We provide an integrated system of care so that it's very seamless to go from getting health care to mental health care, and that way that there's no stigma around it. That's one thing I think that's really important, is doing them both those services together. And we treat the whole child, as I mentioned. So the mental health, the nutrition, the physical health. You can't look at one piece of health care in isolation. And being inside the school gives us such a great opportunity to not only improve the health, as we said in our mission, but also the academic success of our students. And sometimes our teachers, because while we don't treat our teachers when they're sick, we give a lot of over-the-counter meds to them. We can, some of them are having to get their weight or their blood pressure monitored for their physicians. We'll keep logs and fax them to their physicians. And we know that helps keep the teachers in school, so they don't leave school a lot of times if they're not feeling well, just being able to have some over-the-counter meds on site. And, of course, we treat all the teachers' children, too, so that also helps keep the teachers on the job and reduce absenteeism rates. The services we provide include diagnosis and treatment of injuries and illnesses. We give a lot of immunizations. You might not think when kids get to high school that they still need immunizations, but we provide all the immunizations recommended by the Academy of Pediatrics, not just the ones needed for school entry. So we do a lot of additional immunizations, and of course we give the flu every year, flu immunization. We do some lab tests on site. If a student comes in with a sore throat and one of our mid-level providers thinks they possibly could have strep throat, we can swab their throat on site, do the test on site, and diagnose it right then and there. And if it is positive, then we call the parent and say, where would you like us to e-prescribe the medicine to? So all without the parent having to leave work, whether the parent be a teacher in the classroom, or many of the parents in Rockingham County work hourly jobs. They get very little vacation and sick time, and it's a hardship on their families if they have to leave work to take care of their child, to take them to the doctor. For lab tests that we are not considered waived lab tests that we don't do on site, we can send those to the 2 hospitals and get any of those run too. We provide assistance with social work, again, getting to the whole school, whole child model. We know that if the child's hungry, they're not going to do well, so we work closely with all the agencies within all the people in the school, like the backpack programs, but agencies in the county too, to make sure our kids aren't hungry. We do a lot around abuse and violence intervention, and refer out when necessary. We do not do any dental services on site. It's very expensive to do dental services on site. That's something I would love our centers to do one day, but right now we'll just screen and refer them out and help them get a dentist to see them. We do lots of physical exams, just yearly well child exams, and also, of course, sports physical exams. We do the vision and hearing screens for the high schools. I mentioned we give over-the-counter meds. For mental health, we do screenings, assessments, therapy, and counseling, and sometimes the problems we identify, we will refer the students out, particularly for mental health medication management. Our on-site nutritionist does counseling, and then the health educators can do programs and support groups and individual one-on-one counseling. And we do not distribute any birth control, but we do test for pregnancy and prenatal care referral. We think it's very important if a student is pregnant that they find out about it, so we can connect them to a healthcare provider quickly for the sake of the baby and the mother's health. Just some statistics from last school year. There were 3,163 students registered in our center. A student cannot use our health centers without parental consent. So the parents have to consent to all the services and agree to it. 90% of the total high school kids enrolled in the high school had permission to use our center last year. We typically run between 89 and 95 every year. The first year we started, we had 45%. And then it jumped every year. So it took a little while to build the trust in the community, but once they saw this as a good thing, everybody pretty much jumped on board. We, of this last year, of the students that could use the center, 52% of them used it. And of course, some of the students that use the center use it very frequently, our most needy students, and that's what we're there for. We will serve any child regardless of their home situation, of their financial status or insurance, but the most needy students are the reason we're in the school. We had almost 9,500 visits to our 4 health centers last year, and about 13% of those were for behavioral health, mental health. The other top reasons are for ENT and respiratory issues, headache, pain, physical exams, including our sports physicals, and GI issues, including stomach pain, nausea, and vomiting. So you see headache is on up there, and what we realized early on that is always going to be high on our level of visits, because every year we get a new crop of 9th graders in the high schools, and they have to kind of check us out and make sure we really are confidential and a safe place. And many times, they'll come a few times with a headache, and then we'll find out what they really want to talk about. So it takes a little while sometimes. The users by gender, you can see it's not quite 50%, but typically minority males do not access, adolescent minority males do not access traditional healthcare systems. Males in general don't, but in adolescence it's minority males. And so we work really hard to reach out and make sure that we're not just connecting with the females, because all our staff is female right now. Sometimes we've had male counselors, we don't right now. So I think it's like 47%, I can't see the number from here, were males last year, and that's pretty good. So we're pleased with that. If you look at our users by race, we have more minority students using our centers than the percent of minority in our county. So that's good too. You want to make sure that you are attracting the kids that are not getting health care elsewhere. And then we also have more Hispanic students using our center than the percent in the county. Users by insurance type, if you add up uninsured, health choice, Medicaid, it's 60% of the visits, just about. So still, we're seeing a lot of kids that do have traditional insurance, and many of them, even though they have insurance, have really high copays and deductibles. So they are insured, but for all practical purposes, they're not getting the health care services they need. So a lot of people ask, why do you need mental health, behavioral health services? Well, we know that 22% of children and adolescents in the U.S. meet the diagnostic criteria for having a behavioral health disorder with impaired functioning. So that's really high, 1 in 5 kids. 16% have some kind of impairment in function in addition to these 21%, but they don't have a label of a behavioral health disorder. So when you put those two groups together, that is a huge amount. And this is over the U.S. This is not at all in our county. And 13% of school-aged children with typical functioning have parents with concerns, so have parents with some kind of behavioral health issue themselves. So that's why we have to address behavioral health. We cannot just treat physical health because it's so intertwined, and it's exciting to see the whole school, whole community, whole child model, because that in fact does address all the needs of the students. And we also know from data that half of all behavioral health issues start prior to age 14. They're oftentimes not diagnosed, but when they go back, they can see it is. Bipolar disease, for example, typically occurs during those high school or early college years. So it's really important to get kids screened that need screening and get them the medication and the therapy they need. It also helps keep our schools safer. We know having on-site daily crisis intervention really helps impact how kids act out sometimes. They can come to a safe place. They can tell us their fears. It's confidential. That being said, we have speed dial to our lead EC teacher who used to head the crisis team, and we are in constant connection with her or our lead school psychologist, because if we do determine a kid is suicidal or homicidal, we connect with the school right away. So we're not going to share everything because sometimes kids won't share with us, but whenever it's appropriate, we will share with consent. But if it's suicide or homicide, we will share with the school. We want everyone around that child to envelop that child and keep them safe and keep the rest of the school safe. So we work very closely with some of our high needs kids. And then we're also starting to see in our county, and I'm sure across the state, that we have the children that are victims of their parents' abuse, particularly now with the opioid epidemic. And those kids need therapy too. It's really a struggle for them when their home is so unstable. Some of the screening tools we use to identify concerns, mental health concerns with the students, we use a web-based online rapid assessment of adolescent preventive services called RAPS. It is evidence-based. The kids, we hand them an iPad, they answer a 31 question, and it goes into a lot of this whole school thing. It also looks at the strengths and difficulties as part of our initial parent consent form, and then we administer a PHQ-4, which looks at depression and anxiety. Any of you that have been to a physician's office lately have probably been asked to fill out a depression screen. Mm-hmm. It's part of the meaningful use. You fill one out every time you go. You get tired of filling them out. And you'll usually see a PHQ-9. But because we're working with adolescents, we have chosen to do the PHQ-4, which is 4 questions, 2 anxiety, 2 depression, because we know there's a great amount of anxiety among adolescents that has not reached the level of depression but still needs to be addressed. And then if it's positive, there's 2 additional screening tools we do. So sometimes the kids say, oh, we have to fill out another piece of paper, but they're very short little ones. And while our goal is to keep them in the seat in the classroom, we know that it's very valuable information we get from these screening tools. So the healthy school environment, it really, as I've said, we provide a safe physical space and a healthy and supportive space for the kids to come and tell their concerns. So while we're embedded into the school, we're separate from the school. So we in the health center work under HIPAA and not FERPA. So if we think a student needs us to share or they should share something with the teacher, we get them to sign a consent. And usually, I mean, I would say 99% of the time we can talk the kid into that. It might take a little while, but we can talk the kid into that if we think that it's really beneficial, that the school needs to know what's going on. And teens have a lot of troubling issues, and sometimes they really just do want to talk. You know, they're not depressed, but they need someone to talk to help them navigate a certain situation. And they perform better in school if they can get beyond that. I mentioned all our screening tools we use, and then I think I've also mentioned how we really work closely with the school. And we connect kids to resources within the school, especially the academic ones, but also outside the school. And while we have the health centers on site in each of the schools, we do programs from time to time to target risky behaviors that are more school-wide. One of our most popular ones was a parent-teen education session on cyber safety and bullying. I think it's time we do that again. Unfortunately, that issue never goes away. We've also partnered with our sheriff's office to do a texting and driving video. We got some kids in one of our high schools to write a script and film a bullying and sexting video. We got a couple $1,000s to buy them some little equipment and let them have fun with that. We had final edit, of course, but that was good. We've done buckle up campaigns. We see kids buckling up in the front seat, but not always in the back seat, so we kind of harp on that and do different things with that. Each school we have a bulletin board, a big bulletin board in a main area that we rotate health information on. We have lots of videos and brochures that the teachers can use in the classrooms or the kids can pick up. And then we promote abstinence. We have the Baby Think It Over dolls and the empathy bellies. So our classroom teachers can use those. So I've talked a minute about how we increased attendance with the teachers by keeping them in school, but we definitely increase attendance and academic outcomes with the kids. So it doesn't matter if they can pay. We do bill insurance, and I'll talk a little bit more about that in a bit, but it doesn't matter if we ever get any money. Any kid whose permission from their parents is given can use our health center for any of our services. And it's easy to use. The kids are there all day. They can come. We are connected to Power School, so we know their schedules. They're not coming out of their calculus class. They're going to come out of their PE or a non-core class. So unless they're really, really sick at that moment, but if we're scheduling an appointment for a mental health or nutrition or a physical exam or to give an immunization, we're going to get them at the best time in their schedule to get them. And our teachers are great about working with us. And we can call into the classroom, and if they have a test, they'll send them at the end of the test. It's really important to have that good connection within the school because you really want to make sure that you're keeping them in their seat, in their class as much as possible. And of course, having the center on site, they don't have to worry about transportation. They don't have to worry about finances. Our county is a provider shortage area. It's designated as a federal provider shortage area for both primary care, our mid-level providers, our nurse practitioners and physician's assistants, and also for licensed mental health counselors. So by having the services there, they can get on-site care. Medicaid students have a hard time finding a primary care provider in our county because there's little capacity remaining anymore. Most of the practices have reached their limit of how many Medicaid patients they're going to accept. And like I said, for us, it doesn't matter insurance or no insurance or Medicaid. So it's an easy access. We work, if a student does have a primary care provider, we work closely with them to manage their chronic diseases. We're particularly targeting asthma and diabetes and starting to look at some of the outcomes around those. Are there less days missed of school when we treat and manage those conditions on site? When they don't have to leave school to go to the physician's office, of course, they're going to be in their class, and I'll show you a little chart on that later, but they're going to be in their seat longer, and we help reduce and eliminate risky behaviors responsible for much of the teenage morbidity and mortality. So by doing our risk screens, we can zero in on, say, kids that are riding with a driver that's been drinking, or kids that are binge drinking or not wearing a seatbelt, and we can do targeted education towards their risks to help reduce them. We know that detecting illness and issues early on can make them less costly and less traumatic to the student. And we work to improve both test scores and graduation rates by keeping our kids healthy and addressing the needs of the whole child. One of the ways that we reduce the barriers, another way, is by having that mental health counseling on site, and then making sure that health and mental health are going hand in hand and are fully integrated. And there's really a decreased stigma associated with receiving behavioral health services in the school-based health center as opposed to outside of the school-based health center. The first year our centers were open, we had no mental health services on site. I would see a student that clearly needed mental health services beyond what I as a nurse could give them and try to refer them to the mental health department. I'd even call and make an appointment with them, talk to the parent. Not one that whole year ever went, not one. And I wish we still had the data from those early years to count that. So that next year when I became the director, I drove over to the mental health department and I met with the we had a county mental health department at the time. Those have all gone away now, but I met with the director there, and he said, I mean, I didn't know what I was going to ask him for exactly, but he said, I'll send you a therapist one day a week to each high school. And that was amazing. Unfortunately, it didn't last forever, but it was amazing. And so that really opened my eyes to what a change that could make in the kids' lives when they had the counseling they needed. And they were so receptive to it, but they would tell you, I'm not going to the mental health department, I'm not crazy, I don't need to go there. But they did need services. So, and I think we do a good job of reaching hard-to-reach populations. I mentioned both males and minorities, and also re-engaging those disenfranchised, disconnected youths, the ones that are kind of on the edge, that are out there, that are lonely. They have a place to go, and that sometimes is a very calming thing for them. And I think really, again, keeps our schools safe and helps keep them in school. One of our high schools, we happen to have a little group of fellas that comes by every morning. They get dropped off of school almost an hour early, and they come by one of our health centers just to get a hug from the staff and just to start their day. On report card days, they bring their report cards to their centers. And it's really such an amazing thing to see, these big, tall, lanky high school boys that, you know, most people love the little kids, and they're all on board about that. And teenagers maybe aren't as easy to love, but these guys, they're amazing. They really are. And they all have problems, but they're just sweet little boys when they come in there every morning and start their day off. And then we work closely with the schools in developing their care plans and their IEPs because, of course, we have all that information on the kids. Why should people or schools and companies put money into school-based health centers? Well, we know that when you match education and health together, it's going to boost academic success. We encourage parents to be involved in their child's health care. I was a little naive when I first started working here. I thought every parent would want to be involved in that. And some parents, because of all the stresses on their lives, they don't. So really trying to reinforce to parents the need to take care of their kids' health is so important. And we complement the existing healthcare systems and coordinate care with other providers in the county. We don't want to duplicate the care the kids are already getting. We're not trying to take kids away from their primary care provider. We want to be able to give services to those kids that won't otherwise get it. And it's hard for families to navigate the healthcare system. It's hard for anybody to navigate it, but for some of our families that are struggling to put food on the table, it's even harder. And we can act as a resource to them to link them with all the different resources in the community. Sometimes that's making the phone calls for them. Sometimes that's getting them written out directions. Whatever it takes, we're going to try and help get them there. And it does, in high school, the parents aren't around as much as they are in elementary and even middle school, so it does help strengthen that connection. We keep parents on the job and reduce their work absences, and we help keep children out of the hospital and the emergency departments. We did a big study after we'd been open about 4 years with our 2 hospitals and saw ED visits went down among the teenagers that were using the school-based health centers. And then we removed the barriers to promote success for the whole child. We're working with the National Assembly on School-Based Health Care to develop national data on seat time saved when kids use a school-based health center. We're also doing a better job to upfront target the kids that are at risk by working closely with our school staff and knowing in 9th grade who's at risk. And I'll show you a little video clip in a second of a guy that we didn't connect with until his junior year. And what a shame we had in 9th grade because he hadn't come down to the center. So we're trying to do a better job of that. And we're looking at the percent of students who have had an annual physical exam, a BMI, so their height and weight, and with physical activity and nutrition counseling done, and who've had annual physical exams and risk screenings, and a depression screen. So that's what our National Alliance of School-Based Health Centers is working on. And North Carolina had 4 counties that were chosen to be part of this. I think there was 30 counties across the nation to work on developing these outcomes, and it's been a really good thing. I think it's moving school-based health centers forward. We need more data. We know we're helping the kids stay in school. We know we're doing good things, but we haven't always been really good about collecting the data. And we have a cross-county collaborative that's really looking at implementing best practice mental health therapy in schools. And our other counties are Forsyth County and Wayne County. So we have a rural, a semi-urban, and an urban county, and we're comparing our risks across them. And it's interesting to see because there really are differences. And now we're trying to get other school-based health centers in the state to start using the screening tools we use so we can look at the data together. We're starting, of course, now to look more closely at the social determinants of health. Our RAPS, our assessment that we do, that the kids do online, does capture a lot of that data. And anyone that goes and gets mental health counseling, all of those social determinants of health are pretty much looked at. But we're doing more now on getting that on all the kids. And providing more trauma-informed care based on results of our screening tools. We haven't always used screening tools, but now that we do, we realize how valuable they are. And we want to make sure we're seeing our most vulnerable students and the ones that really need our services. So some of our data last year, 96.8% trusted the student health center to be private. And that's important when before they tell you, we had a student, I guess, I think it was a week before spring break, that said, I didn't come to school yesterday, to his counselor because she said, you were absent. Why didn't you come here visit? And he said, I didn't come to school yesterday. And she said, why not? And he said, well, I know I was going to hurt someone if I came to school. Okay. So, of course, then we got the school informed and connected. But if he didn't think we were private, and we tell them when we're going to break it up front. The first visit, they know, okay, if you're suicidal, homicidal ideations, we're going to break all confidentiality. Or if it's reportable abuse, we're going to do that. But it's really important they see it as private because he had that trust all along, and then finally that one day just told her. So, and when we asked the students if they missed less school, 71.5% said they missed less school. Oh my gosh, you can't see this table. But so I talked briefly about the national data that we're collecting, and our school-based health centers in 3 of the measures did better than the state and national average, and in 1 of the measures we were equal to the national and 2% lower than the state, and that was physical exams within the last year. And the reason that we want to do better, but we only have 2 mid-level providers that can do it. We have 1 nurse practitioner and 1 PA for both the centers, so we have room to improve on that, but we were pretty excited with our scores. We decided as a team we were going to hit these hard and work on these together, and that's why a lot of our screenings were done. So funding is always a challenge. It's like a jigsaw puzzle every year, fitting the pieces together. If you had told me in 1995 when I took this job that it would still be so difficult to find funding, I probably would have said, I don't think that's the job for me. But it continues to be challenging. Even though our county is really behind us and we have all those partners, it's still not enough money to run the centers. So every once in a while, there's a federal grant out there you can apply for. But there has been, to date, 1 federal grant for school-based health centers. Now, if you're a school-based health center that looks a little different, like a federally qualified health center, there's lots of grants out there. But if you're under a hospital or if you're a standalone, then there's not. Every year, there's 1 state grant. Well, every 3 years, the state DHHS puts out a grant for school-based health centers in North Carolina, and it's competitive. And if you get that, it's great, and we've been really blessed to have gotten that every year. And then you can apply for another state grant through the Office of Rural Health. And I've pretty much told you about who all our partners were. So they provide dollars and or in kind. So some of our staff is in kind, which really helps with our expenses. And then if a student has insurance, we bill insurance, Medicaid and private insurance. If they don't have insurance, they pretty much slide off our sliding fee scale. And then the rest of the money, the bulk of our money, we get from foundations. So it's applying for grants every year. It's doing something a little bit different so that you can, again, apply for a grant from somewhere. So it's expensive. Dollar amount is, and we get a lot of in-kind above this, but our dollar amount is about $250,000 a year per center. And we do it on a shoestring because we rotate our staff between centers. Some people have asked, why do you need a school-based health center if you need a school nurse? We work really closely with our school nurses, but we're different than our school nurses. Even the nurses in our center are different than our school nurses. We love our school nurses. We share a lot of information with each other. But how you work together across the state varies by county. I think in ours, it pretty much freed them up to devote more time to the elementary and middle schools, but we connect a lot around students still in the high schools. And really, we're all working together to support the whole child and improve overall school health. School nurses can focus on all the students in the school, but again, we can only focus on the ones that are enrolled in our program, which at the end of last year was 90%, so that's still leaving 10%. For the most part, those are students whose parents won't sign because they say, my kid doesn't need this, I take him to the doctor. Again, school nurses both seek to improve health and learning and support the school staff with health issues. We collaborate. We do a lot, especially from that 8th to 9th grade year, and we want to make sure we're not duplicating services. And I already mentioned HIPAA and FERPA. It's two different things, but we really don't have any problem getting the written consent to share. So just real quickly, in North Carolina, there's over 90 school-based health centers. They have elementary, middle, and high school students. 26 counties have at least one. 67% of them are located in rural areas, and 35% are located in high schools. And that's a map. So when you think of coordinated health services, you think of the attendance, and that's one thing that school-based health centers work very hard to boost, just not only the hours per day in their seat, but that they are in their seat every day. And achievement. We know if they're not healthy, they're not going to be achieving. And student behavior and mental health. That is so important to coordinating the health services and focusing on the whole child. And we know then our students will have good outcomes if we do all of this. And then, so it's just, I think, that collaborative, integrated model that works so well. I'm going to end with a little story from this little fella that we didn't know for the first 2 years.
I'm a junior, and I want to tell you all a little bit about how Morehead Student Health Center has helped me. Life's not always been easy for me. My parents have a very pressing medical issues, and I have to cater to them, and it takes a large mental toll on you. But having the health center here, the therapist specifically, has helped me so much to increase my happiness and go from my day-to-day life. And something else they help me with is the car. I don't really have a ride, so when I need to go to like a doctor, I can just come here, and it's very convenient because it's already at school, and I don't have to beg somebody to take me somewhere. And since I've came here, my first 2 years when I did not come here very often, I missed 60 days, but now I have nearly perfect attendance. Thank y'all so much.
So that's Stephen. He's one of our sweethearts. And when he says he has to cater to his parents are both disabled. His dad is a double amputee. By catering to his parents, he means he gets up and helps take him to the bathroom at night. He helps dress and bathe his dad before he has to come to school. He has so much baggage before he hits the door, and he's one of our little fellas that comes by in the morning. And I feel so badly we didn't know him the first 2 years because he has needed so much mental health counseling. And then also, of course, he's gotten immunizations in his physical health care. But we were glad he found us, and I think he says really clearly how much it's helped his attendance and his grades. And I met him one day, and I said, I'm going to give a talk. It wasn't this talk, it was another one. I said, what you just told me can we film that real quick? And so that was totally off the cuff. And that was just really from the heart. This was sitting on the exam bed in the health center one day. He's a neat little guy. So I really think that it's worth investing in our students now. It takes a lot of money, but it saves a lot of kids from dropping out of school, not doing well at school, and not being healthy. So we think its benefits are very far-reaching.
We thank you very much. That's a very powerful presentation and doable. Tough, but doable. A couple of people had already said, how do they fund this? And so I'm glad you had that slide because that is still difficult. When you talked about the reduction in visits to the emergency room, that would be interesting to put a dollar figure on that compared to the $250,000 you need to operate one of these centers.
It would, and both our hospitals do give us a lot of in-kind support and also cash every year.
Because it's saving them a lot of money by cutting down on those ER visits.
It is.
We are, and Mr. Alcorn, I realize we're at 1:50 is our due time. Is that all right? Okay. I know there are probably some questions. This is a wonderful support to what we've talked about with the whole child model, but seeing it in action, seeing it work in a county with the right leadership is really important. Questions, comments from Ms. White?
You mentioned in your presentation that 90% of the students, I'm assuming parents give consent.
Yes.
For the students to access the services.
The parents have to fill out a health questionnaire and sign.
Can you talk me through what happens once a student is seen in the center and some sort of service is provided? How do you communicate back to the parent?
That's a good question. So if they came, for example, for a headache, we would just tell the student, because these are all high school students, we would tell the student, tell your parent or guardian, came down for a headache. So if it's a very minor thing like that, if it reaches a level of a sore throat with an antibiotic, we pick up the phone and call the parent. As you probably know, some visits are confidential by law. So without the child's permission, we cannot call the parent. And that would include mental health, substance abuse, and pregnancy. So it just depends. But we have never, ever had a student tell us something that we knew the parent needed to know and not given us permission. Now, it doesn't always happen that day. But to us, they're kind of a captive audience because we can call them down to the health center every day if we need to. You know, sometimes kids are really afraid to tell their parents they're pregnant, but that parent needs to know. And it might take a week or two. And we tell them, do not tell a soul until you tell your parent. And we're going to call them down and get them, and they will tell the, thank you, they will tell the parent eventually, or the parent will come in and we'll all tell them together. But if it's very uncomplicated, minor thing, we do not call the parent every time. And part of the reason for that is their age. They're soon, a lot of these, when they leave in 12th grade, may go on to the armed services, they may go on to college, they may get a job, they may leave home, and they need to start being a little bit responsible for their own health. So we leave that on them. And the parents know that. In their consent form, we tell them up front, okay, if it's this, we're not going to call you. If it's this, we are.
Other questions or comments?
Yeah, I'm just so impressed, and I'm thinking about the workload, and when I think about, I know it's a health center, but when I think about clinics, I'm thinking about that workload and the waiting room being so full, but I'm also trying to figure out where to from here for us. Do you have policy or law changes that you would recommend to the state that could expedite your work or give you make your work easier?
Well,
and then I guess the second question, and I'm not sure this is of you, I'm assuming, Tricia, that we're hearing this so that we can take this to scale and hopefully take this elsewhere in the state. So the two things.
Well, I'll just address that by saying this is consistent with our whole child pilots that we have going on. But, you know, we brought, I guess back in October, we brought some success stories with that model because it's important that people see how it's being done and the effective
Well, I got about 30
You said
counties
it.
I'd like for you to make this
Yeah.
presentation in,
Yeah,
if you,
exactly.
if you don't mind. And Rodney knows where every one of them are, so
And to his first question, are there policies or things that you see as either barriers or things that might help expand this?
I think the biggest barrier is cost. There are some grant funds, as I mentioned, from the state. The amount is a little bit less than when they first gave out grants for school-based health centers, but the number of school-based health centers has grown significantly. So our centers have been lucky. It's a competitive grant process, and we have been lucky and received money every 3 years in the grant cycle, but the amount we receive is less than before. And so I think if more money was put in the state budget to go specifically for school-based health centers, it would be a tremendous boost. Dr. Shotwell mentioned the Moss Street Partnership School. We're in the process now. I've written a couple grants to see if we can get funding to open the site, but we haven't, they're in the grant process, so we'll see. First, we're trying to get capital funds to remodel a classroom into a health center.
Would Medicaid expansion be helpful?
It might, but I don't. Typically, a lot of what goes on in a school-based health center is not billable. So you cannot bill for nutrition visits. You cannot bill for RN visits. And so if an RN is there and not a nurse practitioner, because we do it more cheaply than some centers, we rotate them. So 50% of the time you're going to get a nurse, 50% of the time a nurse practitioner or a PA. And, if there's an emergency, we can move people around. We don't like to, but that's just the model that's worked for us for a reasonable cost. And so Medicaid would not expansion would help a little bit, but not as much as you would think.
It would help on the billable.
It would help on the billable for the nurse practitioner and the PA.
Right, and so in a larger district, it might be more helpful than
Yes.
Rockingham.
If someone had multiple, and some centers do, they'll have, one in every site.
Right. And I just want to reiterate what Cathy said, that this isn't a replacement for the school nurse or the school psychologist. This is an also, because this is a really important additional support for students who need it. So I just want to reiterate that.
And we had a time when the school psychologists had their own grant, and they would come into the health centers as our mental health counselor, and that worked great. But then they lost their grant. But they did that for quite a few years, and it was wonderful. And we still are benefiting from that because we have such close connections with them now. Right. So that still really is helpful.
Well, very impressive. Is there any other question or comment before we wrap this up? Very impressive, and we appreciate your coming today. Dr. Bell, Dr. Shotwell, thank you for the leadership you all have provided, and how terrific to have a director who's been there to provide the consistent leadership and know how to keep this operating, all in the name of serving children.
Thank you so
Thank
much.
you very much. That concludes our HRS.
Great presentation. Thank you, Ms. Willoughby. Your early recognition of the need for these health centers and the creativity and persistence to fund them makes a model for all of us to try to follow. Mr. Alcorn, I now recognize you for the Business Operations Committee.
Chairman, I'm Greg Alcorn, Chair of the Business Operations Committee, along with Todd Chastain as Vice Chair. Two actions on first read. Biz Op 1 is the School Nutrition Equipment Assistant Grants, and ask Janet Johnson to come forward and talk to us about that distribution of $813,000.
I'm not sure this presentation is going to follow that one. I'm just in awe on that one. So, Mr. Chairman and members of the board, thank you for the opportunity to share our recommendations for the current round of our equipment assistance grants for schools that participate in the school nutrition programs that we offer. This is our ninth round of the grants for this purpose. Many of you already know that in the 2017-2018 federal budget, it included an appropriation to assist local schools in purchasing commercial equipment for the use in the school breakfast and lunch programs. And as already mentioned, North Carolina's appropriation was $813,654. Any school that participates in our program, breakfast or lunch, is and also in good standing relative to program compliance, is eligible to apply for these available funds. Federal regulations require the state agency to use a competitive process. Schools were required, or SFAs were required, to complete an application, send in various documentations to support the application, and the criteria for awarding these grants were established by the U.S. Department of Agriculture, and they pretty much required us to determine equipment that performed one or more of the following functions: was to improve food safety and quality, increase energy efficiency, increase student meal participation, improve nutrition integrity or implement our nutrition standards, and to allow for adoption of innovative meal strategies. We chose to add a sixth function, which was that the equipment would be able to allow the schools to offer more locally grown fruits and vegetables. The section followed the board's policy on awarding discretionary funds. We had a 5-person committee that reviewed and scored the applications received based on these 6 criteria. And as required by USDA, preference was given to those schools that had the highest percentage of free and reduced, and or schools that had never received grants in the previous 9 times. We had 48 SFAs that submitted proposals in an excess of $1.8 million. So we had a little more than to apply than we had funds available. Of those, 40 were traditional public schools and 8 were from charters. And as you review your documents, you will see the recommendations listed by education district, which includes the specific equipment requested and its actual cost as quoted in a vendor's bid. While the committee would like to have awarded funds to all who requested because the need is great, they recommended those shown in the table based on the rankings of highest to lowest application scores until the funds were depleted. Thank you for considering our recommendation for distributing these funds.
Very good. Any questions or comments? Okay, those grant requests will be provided to us to vote for on tomorrow.
Thank you.
Johnson. Very nice. Next, Biz Op 2 is the school bus driver compensation and employment report. That's for the Joint Legislative Committee. And Kevin Harrison, welcome. I'd like to hear what you have to say about this.
Well, thank you. Thank everyone for being here today and for having me. So in creating this presentation, I realized it was very data-driven and clinical and about the reports. And I wanted to start by, if you'll allow me some leeway, to just say that to adapt a little bit on the fly and say that I'd like to tell you what you get when you get a school bus driver. So school bus drivers transport approximately, well, a little over half the students in the state each day to school, about 1 million miles of road traveled each day. They maintain order of a class the size of which we would not expect anyone else to maintain, while primarily focusing on everything that goes on outside the vehicle. They are counselors as well as disciplinarians. Some children will spend years with the same bus driver, and some their entire childhood, especially in small districts. And so children, in many cases, will develop greater and stronger relationships with those school bus drivers than they will with any other member of the school system. They are our everyday heroes in that they anticipate danger on the road and they protect what many of them consider to be their own children. And they are our true heroes. In the last few years, a few examples come to mind. Alice Bradley of Macon County was credited with preventing a mass shooting because when she arrived early to school, she drove her car towards people pointing guns at her, a couple that was pointing guns at her. On the school's campus. And then Crystal McGirt of New Hanover County was credited with locating and saving an abducted child who had been tied up in the woods when she connected a report of an abducted child with something she had seen on the road that day when transporting kids home from school. If you remove the context, school bus drivers do things which we would never expect possible of most other people. And so I just wanted to tell you that as you look at some of the information about what school bus drivers, compensation and employment for school bus drivers, just keep in mind what it is that we're getting for that. So we were instructed in session law last year to conduct a study or a report of, prepare a report of compensation related to hours, how much experience they had, their career paths, and anything that the LEAs believe were challenging with recruitment and retaining school bus drivers. And to provide recommendations largely based on input given by school administrators. We partnered with the Institute for Transportation Research and Education at North Carolina State University, reviewed industry articles, Bureau of Labor Statistics data, and a lot of LEA reported data, as well as information we collected specifically for this via a survey. To give you an overview, becoming a bus driver involves 3 days of classroom work followed by 4 tests, which must score an 80% or better in all 4 of those tests. It requires driving record checks, drug testing, background checks. It requires a federal DOT medical exam by a federally certified DOT medical examiner. It requires you to acquire a CDL license, which is essentially the same thing that people are driving 18-wheelers with. They have to get a learner's permit, and then they have to wait 2 weeks before they can even get behind the wheel to test. Then that's 3 days behind the wheel training, followed by a skills test, or as many days as is needed to pass the skills test. And then they can acquire a full CDL license that they can apply to any job that they could drive a CDL, any large truck job. The average time to complete this process, LEA's report, is 54 days from the time you have somebody starting the class until you get them through the on-the-road training is almost 2 months. And some LEAs are reporting that it's actually taking months longer than that, depending on the availability of DMV trainers. The average upfront cost to a potential school bus driver applicant is $260. That's money they've got to have before they can even get the job. To give you an idea of compensation, hourly and yearly compensation, the hourly wage looks pretty good when you look at it in a vacuum. $14.13 an hour is the average reported hourly wage for a school bus driver. But the common full-time driver in a large LEA is about 7 hours a day, split shift work, and it means that they get, if they work 185 days, about 1,200, 1,300 hours, or about $18,000 for the year, and that's a full-time driver. Again, mostly only large LEAs. Half-time drivers working 4 hours a day are looking at more like $10,000 in compensation, and somebody that's generally driving a quick route in the morning, maybe an hour long in the morning and an hour long in the afternoons, looking at 2.5 hours or $6,500 per year of employment with the school system. So if you break it down, they're not getting paid all that much. The hourly rate belies the actual problem. The biggest problem being school bus driver hours. Now, this is a pretty big table, but the things I want to highlight are highlighted in yellow there, which is that 400. So if you look at this by the size of the LEA, your full-time drivers are mostly located in your large LEAs. You're looking at, and the large LEAs, as first three rows there encompass maybe 15 LEAs, okay? Down there, we got 60 or 70 in the 0 to 99 school bus range. You'll also see most of your temporary workers or your part-time, less than 20 hours, no benefit possibility. Over there on the right-hand side, you're looking on the almost exclusively on the low end, the small-sized counties. Your hours and benefits are key to recruitment and retention. Most school bus drivers work split shifts, meaning that they work an AM shift. They have unpaid hours in the middle of their day, and then they have a PM shift. Whether that be in a small county or a large county, that's pretty much the model. Wake County, you're working 6 a.m. to 9:30, and then you're working 2 to 5:30, but you still got those hours in the middle of the day where you're not working or you're not being paid. Paid benefits, LEAs report paid benefits are highly important. It's easier to retain a driver if you can provide them benefits. The two primary strategies used for increasing hours, multiple routes. 31.9% of drivers drive 30 plus hours a day as a driver. and the most common being about seven hours a day is about average for a full-time driver. But 73% of those 31.9% are located in the 6 largest LEAs, okay? Which leaves about 8% full-time drivers for everybody outside the 6 largest LEAs. So that's not a lot of full-time drivers. To compensate for this, there's a concept of dual employment where a school bus driver will work another job in the LEA. 34.8% acquire full benefits by working a second LEA job. Again, most of those are not in the large LEAs. The large LEAs mostly have full-time drivers. Now, here's the crucial part. Some want this dual employment. They are offered it. It's voluntary. They are said, here you go. You're a TA. We need people to drive buses. You can pick up more hours this way. Some want to do it. Others are required to do it. So some county school systems will say all school nutrition, all teachers' assistants, all assistant principals, and all cafeteria work staff, child nutrition staff, you must all get school bus licenses. At $260, we go get a license. Okay, so some counties will do that, and that boosts that number up a bit. Dual employment prevents shortages. LEAs will report that they would likely be unable to staff their buses without dual employment. They just wouldn't be able to do it, wouldn't be able to come up with enough people to drive each day. It does provide a large reservoir of extra sub-drivers, which is important. But where it's required of non-certified staff, and especially in the case of teachers' assistants, it causes burnout of those positions, and it also can hinder recruitment and retention of those positions. Anywhere from, now, a lot of counties don't require them, so the numbers are a little hazy here, but so hindered to helped as far as retention goes is reported somewhere between 2.6 to 1 to 6.5 to 1 against helping. Okay, so mostly it is a hindrance to retaining qualified staff, although some do report that it is helpful because it allows them to provide extra hours. 1 in 5 drivers have been on the job 2 years or less. Okay, so that's somewhere around 20% have been on the job 2 years or less. And DMV certified 5,000 new school and activity bus drivers in 2017. Keeping in mind, of course, we have about 16,000 regular route drivers and then a bunch of coaches that get activity bus licenses, but they certified 5,000 last year. The average LEA reported 7% of drivers take another job when leaving bus driving. That's a very small number. And they said that most of the time, if they leave bus driving, it's because they got a promotion in their other position and don't have to do it anymore. In smaller LEAs, the staff are more likely to leave the school system for another non-driving job where they can get more hours. But in larger LEAs, they report drivers are more likely to leave for a job driving a commercial motor vehicle, some other type of commercial motor vehicle. So this is all acquired based on LEA reported information. The challenges the LEAs most mentioned, surveys and interviews indicated that the largest challenges were low pay, hourly rates, insufficient hours, the split shift nature of the job, and the lack of benefits. Several of those interviewed in detail, because we did detailed interviews after the survey, connected all of the same issues to pretty much insufficient daily hours for school bus drivers. They just didn't work enough hours in a day to make it a job, and then they didn't have enough hours in the middle of the day where they were free, where they could put another job in the middle. So they ended up having to work other jobs, but not during the 6 a.m. to 5 p.m. time period. So with that, some recommendations, and keeping in mind, of course, that these recommendations are largely drawn from LEA surveys and interviews, and they fall into 4 major categories. The first one being increase hourly wage compensation. Some of these are very innocuous, okay? Last year, there was an increase in hourly pay rate for school bus drivers. If we could do that again, a further increase in hourly pay rates, that would be a big help. Some of them are more complicated. So establishing or permitting incentive-based compensation or bonuses, such as safe driving, student management, or attendance targets for school bus drivers, much more difficult, more legislation involved, more work to do. So that those are just some examples. Increased benefits availability and work hours. So how do we get them more hours during the week if we can't get them behind the wheel because there aren't enough schools to do that, to increase them? Some weekly training time, perhaps with a mentor or as a mentor. So pairing school bus drivers, veteran, experienced drivers with good student management skills with newer drivers to give them the skills that they need. Encouraging LEAs to make it easier for bus drivers to voluntarily gain dual employment. So suggest to them, this may be a good thing. Here's some models where it has worked. Johnston County has bus drivers that drive in the AM and that are TAs the rest of the day, and then have a different driver that is a TA during the day and a driver in the PM. That way they keep each position full, but they don't make a whole bunch of overtime for themselves. So encourage them to do that and make it voluntary. But also reduce the hour threshold for split shift employees to receive full or partial benefits. Among the many possible considerations, that's a tough one legislatively because it involves saying that somebody that doesn't really have 20 paid hours can still get benefits somehow. So that's much more difficult. Enhance recruitment. So we want to enhance recruitment of bus drivers by working with DMV to achieve tighter training timelines. That 54 days is a long time. If you don't have a job and you want a job, taking months from application to getting behind the wheel and getting paid is a long time for you to hold on, especially when you can take that license somewhere else. Provide incentives for non-certified personnel to drive, whatever that looks like. Provide some additional incentive to get them to drive. Maybe that's offering some overtime. I don't know. Reduce upfront costs for school bus drivers. This could be by more LEAs supplementing that those upfront costs, or it could be getting DMV or DOT to pull back on some of those upfront costs for school bus drivers so we can get more of them behind the wheel. Define an intermediate job role to bridge the gap. So right now there's this time gap. You start training and you can't be paid until you are fully licensed and have a certificate and get behind the wheel to drive kids. It would be great if we could define some type of intermediate role so that once they've passed all the background checks and gotten the initial training and passed the tests, that while they're waiting for behind the wheel training, we just say, all right, you are in this temporary role with the intention of becoming a school bus driver, and hold them to a timeline there. And then finally, to enhance retention. Okay, enhancing retention is there are a lot of potential options for enhancing retention. Most of them revolve around improving the school bus driver's life. Okay, making the job easier and providing providing more training. So provide or require more paid hours of training would be very beneficial, especially in the areas of classroom management, which is a skill that school bus drivers need, but probably don't get a lot of, as well as safe driving. Encouraging school-based administrators to support their bus drivers like they would a classroom teacher. Technically, in law, it is the principal's responsibility to treat actions which occurred on the school bus as if they had occurred on the school grounds for the purposes of discipline. But a lot of bus drivers report varying levels of support from school administration, and so they would appreciate more of that. Increased state support for staffing of safety assistance. So somebody on the bus that is an adult that is going to make sure and keep track of the kids and the discipline issues that are going on behind them, while allowing the bus driver to focus on what is their primary responsibility, ensuring all the people outside the vehicle are safe and driving. And then funding the inclusion and maintenance of internal camera systems to further support drivers. That is not, it is variable. Each LEA must choose to do those things, but I think that would be a good way to support bus drivers, because video always shines light on things. And there's also the issue of a service brake interlock. In recent years, the federal government said you really should be setting the parking brake every time you make a stop. And that is just another thing we require of school bus drivers to do. And coming up with the technology to apply that service brake automatically would, one, make the kids safer to make sure that brake is always applied when they're making a stop, but it would also benefit them. It would also benefit the drivers to reduce those repetitive motion injuries from pulling that knob out and pushing it back in. Also, review any other emerging technologies to improve job satisfaction for drivers and oversight of drivers. And, some other options are defining a bus driver training role, and this is so we can move towards the more radical end, and we talk about teachers we assess every year, okay? And there's assessments for teachers every year. Bus drivers largely do not have any type of assessment, but it might be useful to have a bus driver training role where their job is not to drive the bus, but to ride the bus and assess the bus driver's situation and assist them in improving them in their job function. Or, and that has to kind of be paired, though, with a regular required assessment of a driver as you would a classroom teacher. How are they doing? How are they doing with driving? How are they doing with management of the students? And what ways could they improve? So regular assessments of them as you would a classroom teacher as well. And I think those are some really great areas or great potential areas for improvement. As always, the issue is coming up with the funding to do those types of things. But if you have any questions, I'd be happy to answer. Certainly.
I have a couple of questions.
Sure.
Typically, who drives a bus? Are we looking at, let's say, retired individuals or other than school personnel with that split role?
So I think it's going to vary, and it depends on the situation in the county. I think you will get some retired people. Some people did mention in the survey that they tried to target specifically retired staff, but they had trouble keeping them on board because they had issues with student discipline and respect for those older staff members. But it's varied. Some school bus drivers, once they get beyond a few years and they really realize this is something that they enjoy and want to do, they'll stay. We've had drivers stay 40 or 50 years. But yeah, so it varies from county to county.
And then I do have a follow-up question. Is it possible for a student, let's say a senior in high school, who has completed most of his or her requirements and is only in school for a couple of hours during the day, is it possible for that student to drive a bus?
So the federal government instituted regulations to indicate that 18-year-olds were the age to get a federal CDL. It's actually 21, but you can get an accepted interstate license, which means you stay within North Carolina if you are between 18 and 21. That sort of provides an extremely small, narrow window for most high school seniors. But it used to be very common. It used to be that lots of 16, 17-year-olds would get the training, drive for a couple of years, good part-time job for a student because it paired greatly with their situation. But now that's really, with the advent of the requirement of CDLs in the 90s for all staff driving large commercial motor vehicles, and again, that was a few decades ago, that sort of went away because now there's too narrow a window. You could train a student at the beginning of their senior year. They might drive for you for a few months and then they'd be gone. It just wouldn't be worth the money involved.
Now, I was one of those student bus
Yeah.
drivers. I made $32 a month and I was rich.
I was
Yeah.
excited.
Yeah.
Is it allowed for teachers to supplement their income by driving a bus in the morning or the afternoon?
So this is a tricky thing for certified and non-certified. This is a tricky thing for certified staff. Generally speaking, and you would really need to talk to somebody very knowledgeable in employment compensation, I think the answer is likely no because they're a salaried employee. If they were to do it, the best that they could hope for is to not hurt their other salary because the bus driver is going to be paid less per hour than a teacher, and you would be, if you took them at all away from their other responsibilities, or because it's a single employer and you're a salaried employee, you've got a concern there.
I'm a former bus driver. I was one of those 16-year-olds. I drove for 3 years in high school, but then I also drove again as a teacher assistant, kept my license as a teacher and an AP. It was problematic because you would be called in for a random drug test and you would have to leave your classroom, and you know, you ran into an issue of having people to cover your class on those random days. But as you were talking, I do believe that, you know, the three things that jumped to my mind, as an AP, I also handled the buses for my county. So I was in charge of that. You know, definitely higher pay and bonuses that would go along with that. But to have, you know, a supportive administrator that is going to take, you know, the discipline issue seriously and take time to help support those bus drivers. And in order to do that, quality camera, you know, systems need to be put in. Back when I was doing it, they still had the VHS. You know, tape recordings, and you couldn't see it. It was grainy. Towards the end, they did do some of the DVD ones, which was great, and there were at least 3 on the bus, so you could see front, middle, and the back of the bus. So in order to support these people and to be able to give them the you know, the supports that they need to stay in it for, you know, such a low low income, is to provide them with support. So that's what I would really say that we need to focus in on.
Mr. Davis?
No, I don't have anything.
Okay. Well, thank you very much. We
Thank you.
appreciate it, and we will move forward.
Thank you.
Mr. Alcorn had to step out for a few minutes, and so we'll move on to, thank you, Mr. Alcorn. We're just getting ready to move on. Dr. Oxendine, I now recognize you for the Educator Standards and Practices Committee.
Thank you, Chairman Kobe. I'm Olivia Oxendine, and I chair the ES&P Committee along with Mr. Eric Davis. One action item under my agenda portion, ES&P 1, and that is LICN 1001, and Dr. Tomberlin is going to come forward and talk us through that.
Good afternoon.
Good afternoon.
So we are covering a couple, the presentation we have here is to cover LICN 001, which is action, but we're also going to cover the items, subsequent items for discussion, if that's agreeable.
Sure, that's perfect.
And so for the presentation, we're going to look at ES&P 1 and then 4 through 9, and the Educator Preparation Program Application ES&P 3. Just for kind of continuity, I'm going to cover all the licensure policies, and then Dr. Seiberg will come discuss the EPP application portion of this. So the first, the action item we have, again, that's LICN 001, the general licensure requirements. We have solicited copious amounts of feedback from the field about how we would define when a teacher is required to attempt or pass the licensure exam. And this goes back to the definition of a year. Our desire is to align this policy with the salary manual's definition of a year for the purpose of granting credit for a school year. And so in order to do that, the definition is a little complex. So what we're proposing here is that a teacher who works for 6 calendar months in an academic year is held to the testing requirement for that year, whether it's first year or second year. The definition of a calendar month is the number of days employed divided by the number of days in the pay period multiplied by the employee's percentage of employment. And we think it's important to put it into policy so that it is very clear. This is a very detailed calculation and should leave no room for anyone to misinterpret whether they are required to meet the testing requirement in that year. The added benefit is School Business and Finance annually publishes a report called the No Bump Report, which it means a teacher did not meet did not have enough months in the year to qualify for a salary bump. If a teacher appears on that report, that teacher would also not be required to do the testing for that year. And so we have a built-in reporting structure with this as well. So I think we have pleased everybody with this definition, the commission and other stakeholders from the field, and we would recommend this moving forward.
Very good.
As to the items for discussion, ES&P 4 is the Beginning Teacher Support Program. What we have done here is the Beginning Teacher Support Program really is not about licensure. It's about conversion from an initial to a continuing license. And so our proposal here is to take the Beginning Teacher Support Program language out of LICN and move it into a new policy under TCED, Teacher Credentialing Education. So we would delete this policy, LICN 004, and move the BTSP content to the TCED policy. What we would like to, create a new policy, an LICN policy, that that does. I'm sorry, I'm on the wrong slide here. A new policy that does clearly define the requirements for a teacher to convert from an initial to a continuing license. And those requirements include participating in a Beginning Teacher Support Program as part of their, oh, that's in 6? I'm sorry. Looks like I jumped ahead just a little bit here. Or I'm behind. So that would include participating in a Beginning Teacher Support Program as a requirement for converting from an IPL to a CPL. In addition, the teacher would have to complete any testing and or coursework requirements for that conversion.
Dr. Tomberlin, for a point of clarity, so let me make sure I understand this. We have a couple of policies on the agenda dealing with the Beginning Teacher Support Program that now will be removed out of LICN to teacher education.
That's right.
Okay.
So the policy itself, LICN 4, outlines what the Beginning Teacher Support Program is. And so all that language related to the actual program, we're taking out of LICN and moving to a separate TCED policy.
Perfect.
What will remain as a new licensure policy are the requirements for converting from an IPL to a CPL, initial to a continuing.
You're doing exactly why I love the work from Pepsi. Yes, I love it.
Yes. So ES&P 5, the Beginning Teacher Support Program, so this is the policy that would be transferred to TCED. This takes all the, this just relocates all that content with a few minor updates. The first being we have removed the references to what used to be Standard 6, the Student Academic Growth Measure, because we no longer use that as a formal part of the evaluation process, so that language has been taken out. We also had to address a part of this related to mentors for these beginning teacher support folks. At the recommendation of Pepsi, the mentors were required to have proficient or better on all 5 standards in order to serve as a mentor. It used to be accomplished. Given that we've moved to proficient, if a mentor falls below proficient on any one of the standards, they can no longer serve as a mentor. And so we don't want anybody with a less than proficient rating to be serving as a mentor, so that clarifies that language in that policy. I know that was kind of convoluted. Does anybody have any questions on?
Any questions? Okay, you can proceed.
ES&P 7 is related to LICN 006, and this is experience credit for salary purposes. Here we've change the definition of a calendar month to reflect that which is in the salary manual, which we discussed earlier for LIC and 001. So that's just aligning all the language throughout the policies. And it also inserts language from the statute regarding graduate degree pay for educators. That language was outdated and did not reflect the requirements for teachers to receive graduate level pay. And so those requirements are listed in that updated policy in 006. ES&P 8, which deals with licensure 007, suspension and revocation. This policy, we just simply clarify that educators must provide 30 calendar days, not workday notice, to their employer before they resign an instructional position. Failure to do so could result in the suspension of the license for the remainder of the academic year. ES&P 9, LIC and 021, exception to the licensure requirement through extenuating circumstances committee. So this is a committee created by the Board of Education to review teachers who cannot meet the licensure requirements within the prescribed amount of time, and you allow those extensions based on a presentation of the extenuating circumstances by the employee. There was some language in this policy that did not allow an extension past the limit, the 3-year limit of the lateral entry license or the initial license. We've removed that language because there are no longer any yearly requirements for an IPL or a lateral entry. We've made all the requirements due at the end of that 3-year period and no longer have those incremental requirements along the way. So any extenuating circumstances request that the board receives would, by definition, be seeking to extend beyond the 3-year period. And so we took that language out that allowed you to extend the term of the initial or the lateral entry to account for those extenuating circumstances. We make no suggestions or promises that you will extend it past that term, but you have that latitude. And that completes.
We're going to go back to a couple of other items for Dr. Seiberg to make a presentation.
Yes.
And then also, let me pick up with action on first reading. That ES&P 2 will be taken up in closed session. Then we're ready to go to the item dealing, and that the next item is going to be ES&P 3, the draft educator preparation program application.
Yes, good afternoon, everyone. This is an action on first read item that's seeking board approval for the application process for becoming an authorized educator preparation program in North Carolina. The recent law, Senate Bill 599, that passed back in July, seeks to authorize EPPs to begin to prepare candidates for the licensure pipeline beginning in fall of 2018, so the 2018-2019 school year. And so that's why we're bringing this as an action on first read, because we want to try and get that out to the field so folks have enough time to meet that obligation. What's outlined in the law is that the state board will approve entities seeking to become EPPs, or authorizing them is the technical term that they use. Then the State Board of Education also needs to approve a rigorous approval process, which is what I'm bringing to you today. Additionally, a program seeking approval needs to go under some sort of a peer review process that's established by the State Board. And then there's technical assistance to applicants so that they have clarity about the process as well as the reporting obligations that will come on the back end of their program. So the actual recommended application process that we've put together for you all today is we've built an application template that's attached to this item. And in that, it covers all the standards that have been outlined very carefully in Senate Bill 599. And those are the standards that EPPs must meet according to that law. We've From that point then, those submitted applications, once they've submitted that template and met those obligations, that template then goes to a series of peer reviews, not unlike what we have in place right now at the program level. So we'll leverage K-12 and college professors to look at and review the applications that come in and give a peer review on that. Once that's done, then that information, along with the stakeholder recommendations, the peer review recommendations, will come to the board for a formal review and ultimately approval. And then along the way, as there's any issues along the way, we'll be sure to help support folks from our offices to make sure that they have clarity in the process and are well supported to meet the expectations of the process.
Do we have any questions about, this is a very, very important item that's coming before us, because this is going to make sure that these entities who want to get in North Carolina, whether they're already in North Carolina as an entity, waiting to complete the application process and waiting for us to act on, this is new to us, isn't it? We've not done this before, so it's really critical that if you have any questions about this application, components of it, if you need clarity, now's the time to ask, because we're going to be, well, this is action on first read. We're going to act on this tomorrow. Yeah. Do we have some, currently, do we have any interested entities?
Yeah, there is at least one outside of North Carolina entity that's interested, and if memory serves, there's at least one, possibly two LEAs that are interested within North Carolina.
And that is new, LEAs wanting to get into the business of preparing teachers through this process.
Yes, it's first read. Does it have to be first read?
And explain why it needs to be first read, Andrew.
We're just trying to make sure that there's ample time, because in the law, if you look down at Section 7 at the bottom of Senate Bill 599, the last page, it sort of states that the expectation is that entities who become education preparation providers should be able to start for the 2018-2019 school year. So we're trying to get the approval up and running so that we can get this template out to the folks that are interested in applying, so that there's ample time to meet that obligation.
So are we adopting the draft, or are we adopting the application?
Well, it's the application process, of which the draft is a portion of that process.
Do you feel, okay, so it's a draft. Do you feel like this is it?
Yeah.
Yeah, this is definitely it. Yeah, this has been reviewed by a variety of stakeholders. I'm sorry, probably should have taken that off of that.
So, yes, so, right. This is going to be the actual thing that entities will prepare and submit to you and your staff, members of your staff. Right. About how long will it take for the application from beginning to end? Well, how much time are we thinking it will take?
For the entities to apply, you mean?
And then for it to come to us for approval and all of those steps.
Some of it has to do with the kind of depth that they bring in terms of the experience. For an entity outside of the state that's interested in applying, they have programs in multiple states, so they're going to want to leverage data to help reinforce their application. That might take some time, and then once we get it into the department, then we have to hand that out to stakeholders in the field to do some reviews there. That obviously takes a couple of weeks there too. So I would imagine it's going to take, maybe a month for them. This is if they wanted to turn it around like immediately. It might take them a couple weeks to do the actual application with support from our office, and then we have to vet it with stakeholders and then bring it to you all for review and then ultimately approval.
So this is a new function for your section, isn't it?
Yeah, so prior to this, they had an innovation program so that an entity could apply that met very specific criteria. But in terms of an actual EPP level, like the overarching entity, that's not been something that I've had to do, at least in my short tenure here.
So do we have the staffing to do all of this additional work? Probably not.
Well, my guess is that it has, it's somewhat contingent on whether we get a couple applications or hundreds of applications. So the more applications we get, the harder it would be, right?
Harder it will be to try. I see Dr. Tomberlin looks like he wants to come forward.
I just wanted to say a quick word about the expedited process here. In particular, Charlotte Mecklenburg, who had a local ed prep program within their LEA, they discontinued that, and then this law came into effect. So they're applying to reinstate that program, which has history and was approved previously. We need to get. We're pushing this expedited process so that Charlotte can get that program reinstated and get the grant funds associated with building that program. So there is a very real need here that I want to advocate for Charlotte to have that opportunity to get this moving. They will move as quickly as humanly possible once we approve this application.
And some of it is because they have a feel for it already.
This is the reinstatement of a program that had been approved prior to 599.
Other questions? All right, so we're going to act on this tomorrow. Any
Sorry,
other?
I do have one other question.
Yeah, oh, I'm sorry, Mr. McDevitt.
The input process says that you did have input from the IHE stakeholders. Tell me the nature of that input.
So whenever we try and come up with these new things that need to be aligned with law, what we try and do is include.
I mean on this specific one.
Yes, on this specific one, I tried to ask folks both from private institutions and public institutions, large institutions and small institutions, to get their input on those things that we've put in place here in this template to make sure that we're covering all those bases. In this particular instance, I leveraged folks who are really experienced in the CAPE national accreditation process, because they have a very experienced background in that, and so we were leveraging some of that expertise in this particular instance as well.
Let me ask the question differently. If we adopt this, are the IHE folks going to be surprised?
I don't. My understanding is that they are aware that this is coming, and I haven't heard, at least in my conversations with the various folks that I've been working with, there hasn't been pushback either with the Pep-C Commission or the various stakeholders that I've communicated this with out in the field.
One would think so, Mr. McDevitt, but I think the fact that we have on Pep-C, we have IHE professors and maybe a dean, maybe a couple of deans. So, and they're apparently giving a thumbs up to this. They like the idea. They know that there are various ways to prepare educators. The IHE campus route is only one.
I can tell you that the one thing that they wanted to make clear was that it was a level playing field, that the expectations and the data that's being collected and the standards that are being set should be, their concern was that it was level across the board. And that's essentially what 599 has done, is basically said anybody who is an educator preparation program has to abide by these various reporting obligations. And so all of that is level.
And they do have to get in the ballpark. If they aren't accredited by CAPE, they must get in that ballpark and apply. So that has to be verified, and I'm sure your staff and the peer review group will make sure that happens. Other questions? Good job. Jen, Andrew, Tom, good work.
Thank you, Dr. Oxendine. We're going to take a short break until 1/4 It's very short, 8 or 9 minutes.
Are you here tomorrow? Margaret Spellings is here. So Jen and I, we couldn't get a parking space across the street. The state parking sometimes.
They're at the.
This is the president of the UNC system. I only need to take care of one day.
Yeah.
So Jen, Danielle, and I are going to meet Kevin Howell and Margaret at the front door.